And it is my great pleasure to introduce the last speaker of this session, is Professor Franco Locatelli from Catholic University and also from the Pediatric Hospital Bambino Gesù in Rome. He is going to talk about the TMN following childhood malignancies. Please.
So thank you so much, Gennaro and Livia, for the introduction. And let me start thanking the organizers, and in particular, Maria Teresa Bosa, for this kind invitation that I really appreciated because it offers me the opportunity to address one of the most important issues related to the long-term complications observed in patients surviving a cancer suffered during childhood. And these are my disclosures that I leave for a few seconds before starting. Treatment-related amyloid neoplasm, or as we just learned, post-cytotoxic therapy myeloid neoplasm, represent a serious potential complication following treatment of cancer during childhood. And the incidence varies very much in the different reports, depending on different factors that I will briefly discuss in a few seconds. And there is no discussion that the outcome of this patient is still unsatisfactory and certainly inferior to that observed in patients with de novo AML. And talking about the factors influencing the occurrence of therapy-related myeloid neoplasm in childhood. In this cartoon, I try to summarize the available knowledge on these factors, including the genetic predisposition cancer genes, the drug use, the duration of treatment, the dosage of the drug, which is very important, the original disease, and the genomic variants of key enzyme. And in the next 5 or 6 slides, I'd like to give you the evidence corroborating the scheme reported in this cartoon. In particular, our colleague of the NOFO cooperative group reported already 14 years ago that the longer the duration of maintenance therapy, the higher the incidence of therapy-related myeloid neoplasm. Indeed, in the box with the graph of this slide, you can observe that in patients allocated to the standard risk who receive the longer duration of maintenance therapy, there was the observation of the higher incidence of therapy-related myeloid neoplasm. And also looking at the dosage of 6-MP, that is the main drug used during maintenance therapy for treatment of childhood ALL, you can easily appreciate that patients developing a therapy-related myeloid neoplasm had received a higher dosage of 6-MP. And in terms of enzymatic activity, the thiopurine methyltransferase plays an important role. Indeed, this cartoon clearly documented that patients with a lower activity of PNT had a greater incidence of myeloid neoplasm related to the treatment, suggesting that also the enzymatic activity plays a major role in the occurrence of myeloid neoplasia. And indeed, this cartoon further corroborates what I just mentioned. because if you look at the red curve, which refers to patients with a low activity of TPNT, you can observe the higher incidence of secondary malignancies. And from a biological point of view, this is the result of higher availability in the cells of 6-thioguanine, which interfere with the mechanism of DNA repair. So having premised these findings and having commented about the importance of duration of treatment, drug dosage, and enzymatic activity, the next important point that I like to briefly mention with you refers to the mechanism responsible for the development of this therapy-related myeloid neoplasm. And the first comment refers to the fact that survivors of cancer have a 80-fold increased risk of developing myeloid malignancies. And this is something that should be carefully considered in terms of long-term follow-up of these patients, even in the perspective of transition between the pediatric hematologist and the adult hematologist. And sequencing studies on therapy-related malignancies have clearly demonstrated the mutational signature within blast, which is consistent with both prior drug exposure, but also with clock-like signature that are generated in a continuous manner and associated with aging. In other words, there is a sort of mutational aging observed in the hematopoietic stem cells of children exposed to chemotherapy that must be taken into account. And indeed, I think that in terms of pathophysiology, this cartoon summarizes perfectly well what we now know in terms of predisposition to develop therapy-related myeloid malignancies. In other words, there is a sort of accelerated aging or accelerated mutational burden, which is dramatically evident as compared to what is observed in normal population never exposed to cytotoxic treatment. And thus overall, the chemotherapy exposure can promote the occurrence of myeloid malignancies in a sort of double way, namely that of activating the process of development of the classical alterations. For example, I am alluding to the KMT2A rearrangement in patients with a prolonged exposition to etoposide, but also through this increased mutational age. And the mechanism of this acceleration of mutational age is still undefined. However, it is tempting to speculate that the altered methylome of each following of the chemotherapy exposure can persist over time, predisposing to the development of these myeloid malignancies. And indeed, there is a very nice study published by the colleagues of the St. Jude Hospital, which analyzed almost 3,000 children surviving after cancer, and they found an increased incidence in clonal hematopoiesis as compared with controls across all the age groups. And the last comment I like to make in terms of pathophysiology is that the radiotherapy plays a very minimal, if any, role in the development of these therapy-related minor malignancies in comparison to the exposure to chemotherapy. And there is certainly no need in this room to comment on the typical cytogenetic abnormalities that have been found and recorded in the pediatric population. They are very similar to those observed in the adults, namely the monosomy of chromosome 7 or 5, rather than the KMT2A rearrangement, as I mentioned before, in particular to patients exposed repeatedly to etoposide or teniposide in the past. What I'd like to briefly share with you is a study that we conducted some years ago in the consortium called Ponte di Legno. Ponte di Legno Consortium is a network of international groups working on childhood ALL, acute lymphoblastic leukemia, and we wanted to evaluate the occurrence of secondary malignancies, paying in particular attention to the therapy-related myeloid malignancies. And the reason for doing this is that there are still controversy in terms of frequency, as I mentioned before, because it varies widely depending on all the factors that I mentioned before, and also because the data in terms of precise mechanism or factors correlated with the occurrence of therapy-related minor malignancies were not very well defined. And the first important observation that we had in this study that we published some years ago in JCO was that AML and NDS are the most frequent tumor observed in patients surviving therapy for childhood ALL, followed by CNS tumor. And also in terms of occurrence, you can observe that 80% of cases occur within 5 years from diagnosis of ALL, while the CNS tumors, for example, occur in 80% of patients developing this complication within 12 years, and an even longer time was observed for other types of malignancies. The other important observation deriving from this large international effort was that in more than 3/4 of patients with an aberrant karyotype and exposure to epipodophylotoxin had the KMT2A, or at that time MLR rearrangement. And also in this international study, we were able to confirm that the patients who developed therapy-related myeloid malignancies had received indeed a higher dosage of 6-MP and methotrexate. And the other relevant information that we observed was that the KMT2A rearrangement was associated with the classical recurrent cytogenetic abnormalities in childhood ALL, namely the translocation 1221 or the translocation 119, while there was a correlation between monosomy 7 or monosomy 5 with the occurrence of ALL with a hyperdeployed karyotype. And looking at the outcome of these patients, we were able to document that the worst prognosis was observed exactly in patients with therapy-related AML or NDS, as well as, but this is another history, with CNS tumors other than meningioma. Although already in that study, we were able to demonstrate a tendency for improvement in the outcome of the patients over time, as you can see in the right part of this cartoon. So talking about the outcomes means also mentioning which are the hurdles for the management of these patients, and certainly a relevant proportion of patients have complex cytogenetics, multiple molecular abnormalities. We are talking about pre-treated fragile patients with a short interval, as we already commented, between the original diagnosis of cancer and that of secondary NDS or acute myeloid leukemia. And now we have evidence that many of these patients have also genetic predisposition. In particular, I am alluding to the TP59 mutation. And this is a no study documenting the worst outcome, as I mentioned before, of patients with secondary myeloid malignancies in comparison to de novo AML. What is still unpublished, and I am glad to share with you, is this analysis carried out by our European Consortium on Childhood NDS, which is called EWOG-NDS. The acronym means European Working Group on Childhood NDS. And we analyzed 127 patients who were given an allograft. And you can see that the median time interval between the first malignancy and the occurrence was rather short, and many of these patients that we analyze has suffered from previous hematopoietic neoplasia, mainly ALL, but also lymphoma, followed by solid tumors and brain tumors. And again, the median interval that I was alluding to was only 3.4 years. And you can appreciate that 62% of patients had a blast percentage lower than 20%. The remaining 40% had a higher blast count into the bone marrow. And the most frequently detected cytogenetic abnormality was a monosomy 7, followed by a complex karyotype. These patients were variously treated before being transplanted. Someone received intensive chemotherapy. Other patients didn't receive any treatment, and also the type of donor employed and the conditioning regimen was rather heterogeneous. Most of the patients were transplanted with bone marrow cells. So in terms of overall outcome, the 5-year probability of DFS was 43%, and the main cause of treatment failure was leukemia recurrence, although I wouldn't underestimate the cumulative incidence of treatment-related mortality, because it is in the order of 20% value, which is amazingly high in comparison to what we observe in newly diagnosed patients. And the worst outcome that we observed was that of patients who develop post-cytotoxic AML or NDS after an initial diagnosis of a solid tumor. This representing also an important prognostic factor to be considered in the patient's counseling. Not unexpectedly, the worst outcome was observed in those patients with a complex karyotype, and this was mainly due to an increased incidence of secondary malignancy recurrence, while substantially the outcome of patients with either a normal karyotype or monosomy 7 was superimposable. And talking about the outcome according to the highest stage of disease, you can appreciate that there was a much higher risk of recurrence in those patients who at a certain point of their pre-transplant history had more than 5% of blast. This suggesting that probably we should modulate the intensity of the conditioning regimen according to the blast percentage that the patient has developed. Or in other words, if you wish, you can consider to use more gentle preparation in those patients with a lower blast percentage before the allograft. In terms of the classification of the patients, you can observe that advanced disease was associated with a greater risk of leukemia recurrence, while there was no difference in terms of outcome according to the conditioning regimen employed, either busulfan-based or trifsulfan including, and this was true also for what concerned the cumulative incidence of relapse. When we performed the multivariate analysis of all these factors, we confirm that both the complex karyotype and a previous malignancy of a solid tumor remain statistically significant in the multivariable analysis. And we also look in a subset of patients the influence of the genetic lesions on the post-transplant outcome, and you can find further evidence of the detrimental role played by TP53 mutation, because all patients carrying TP53 mutation at the end of the day died. And it is noteworthy that 7 out of the 9 patients with the TP53 mutation carried a complex karyotype. So, and to summarize the results of this analysis, the 5-year probability of VFS is a little bit higher than 43%, with disease recurrence representing the main cause of treatment failure. But I reiterate the concept that also the risk of treatment-related mortality or transplant-related mortality shouldn't be underestimated or scodomized. The EFS was worse in those patients with a previous diagnosis of solid tumor. The presence of a structurally complex karyotype predicted a worse outcome. The use of intensive chemotherapy before the treatment didn't improve the outcome. Patients that were prepared with the reduced intensity regimen overall didn't have a better outcome, but I reiterate what I told you before, namely that we should modulate the intensity of the regimen according to the blast percentage detected before the allograft, and clearly there is growing evidence of the importance of the TP53 mutation, and thus the genetic screening for cancer predisposition genes must become part of the standard of care diagnostic workup in these patients. Thank you.
Thank you very much for your presentation. Are there questions?
I have. Thank you, Frank. Very comprehensive presentation. I have a question for you regarding a slide that you presented where there is, when the patients arrive at the transplant procedure, there is no difference of the results with respect to the blast count at the transplant. It means that if we can do the transplant before any kind of a chemotherapy, could be an option for this kind of patients.
The simple answer is the earlier the better. In the sense that once you diagnose patients with a therapy-related myelin malignancies, you should activate the transplant procedure as fast as you can.
Now, because if you not treat the patients with the chemotherapy, you reduce the risk of infection and to compromise the following transplant.
It's the classical dilemma between the choice of treating or not treating patients. The available evidence do not suggest a significant benefit from previous cytotoxic therapy. What we have agreed in the NDS consortium is that of offering chemotherapy only to the intensive chemotherapy, I mean the AML chemotherapy, only to those patients with more than 20% blast in the bone marrow. In the future, the situation could change, integrating demethylating therapy together with the monoclonal antibodies. And in particular, I am alluding to the monoclonal antibody targeting the don't eat me signal, namely the anti-CD47 monoclonal antibody, or if you wish, magrolimab, just to be clear.
Thank you.
There is a question.
Thank you, Professor Locatelli. That was a very nice presentation. And in the first slides, you showed that radiotherapy plays a minor role in developing the therapy-related myeloid neoplasms. I just wanted a clarification about radiotherapy. That was TBI as
no,
just
it was
radiotherapy.
cranial irradiation for children with ALL, or radiotherapy and solid tumor patients.
Okay. And do you think that TBI could represent a risk in developing subsequent therapy-related neoplasm, or it's just pretty much the same?
It is certainly a risk for certain type of tumor, and I am alluding to the CNS tumor, but not for therapy-related myelin malignancies, because you substitute the recipient hematopoiesis with that of the donor, and those cells potentially surviving the preparative regimen are largely killed by the donor T lymphocytes with the so-called graft versus recipient or versus leukemia effect.
Thank you.
Other question? Yeah, Maria Teresa. Here, we have a question here, in the first row.
Thank you, Franco, for this wonderful overview.
Thank you.
And I would just like to comment on this last issue, because we discussed yesterday the role of the microenvironment in the development of secondary malignancies. And what you just mentioned, that TBI is not associated with therapy-related leukemias following allogenic stem cell transplantation, may indicate that there is not a major role for microenvironments.
Yes, but let me play the devil advocate role. There is a completely different setting. Of course, I am not talking about the therapy-related myeloid neoplasm, but benign disease in which an inflammatory microenvironment in the bone marrow promotes the occurrence of secondary or in general myeloid neoplasm. And I am alluding to sickle cell disease because sickle cell disease is associated with a much higher incidence of NDS and AML as compared to thalassemia. And the only cases of AML observed in gene therapy, gene addition therapy recipients were in patients with sickle cell disease. So inflammation in general in the microenvironment promotes the occurrence of myeloid neoplasm. And it would be nice to study, and this is even a proposal if you wish, the occurrence of clonal hematopoiesis in these subjects, because to the best of my knowledge, this is a study that has never been at least published. I cannot perform, but at least published.
There is a question over there.
And it would be nice, by the way, Maria Teresa, thanks to the collaboration that we had also to study the incidence of clonal hematopoiesis in our children surviving a diagnosis of cancer, just to provide further evidence corroborating and supporting the St. Jude data.
Thank you very much for your very nice presentation. As we all know that both lymphomas and myeloid neoplasms are all derived from hematopoietic stem cells. They are hematopoietic stem cell disease. Do you think these therapy-related in the concept of TMNS, the committed myeloid progenitor cell is more affected than the lymphoid progenitor cell?
Yes, for sure, because the incidence of true secondary lymphoid malignancies is limited. If you eliminate the so-called EBV-driven lymphoproliferation, the number of lymphoid malignancies is limited. Although there are some patients that can develop also other type of at least clonal disorder. In one of the slides that I presented, but I didn't commented for the sake of time, there was the observation that 11 patients with TALL develop Langerhans cell histiocytosis, and this is another clear example of a peculiar subset of ALL predisposing to the occurrence of, if we don't want to call LCH any longer a malignant disease, at least a clonal disease.
Thank you.
I actually have a final question, a different type, since you mentioned at the beginning of your presentation the acceleration of mutational age. So I guess that this mutational, the accumulation of mutations over time, they put under stress, I would say, the immune system. So what is known about, say, the immune surveillance and the studies and the role of immune system as a counteracting way to block the development of secondary neoplasm?
Thank you so much, because it is a wonderful question, but I should ask 1 hour for properly commenting. No, I am joking. There is clear evidence that there is a decline in the immune surveillance function of patients over time, suggesting that this can facilitate the development, maybe not the emergence, but certainly the development of malignant clone. And again, we have just finalized a study that stemmed from the COVID-19 pandemic, because we evaluated the response to SARS-CoV-2 vaccine in thalassemia population. We found initially a similar response between thalassemia and healthy workers, but the decline in the antibody titer was much more accelerated. And this suggested us to study the aging of the immune system in these subjects, and we found an accelerated immune aging, a sort of inflammaging, which is a neologism that I don't like very much, but it is becoming much more popular, more and more popular in the last months or few years.
Thank you very much. Then I think we can close here, and thank to all speakers for being on time. I think we are perfectly on time, and we can have a coffee break as planned.